So this is our change agent project, and we focus on medication errors. So our scenario was based on patient safety and medication errors. So in a busy hospital, the nursing staff has been experiencing a concerning increase in medical errors over the past few months. These errors range from incorrect dosages to medication administration at the wrong times. Fortunately, most of these errors have been caught before causing harm to patients, but the nursing leadership recognizes the urgent need to address this issue to ensure patient safety. The nursing leadership team conducts a thorough analysis of the situation and identifies several factors contributing to the increase in medical errors. So, number one being the high workload. Nurses are constantly overburdened with a high number of patients and heavy workloads, leaving them with limited time to properly check and administer medications. Number two being the lack of standardized procedures. There is no standardized procedure in place for medication administration, leading to confusion among nurses about best practices. So the first stage of Lewin's change theory is the unfreeze, which determines what needs to change. And due to the lack of standardized procedures and high workload, there's been an increase in the number of medical errors. So what needs to change is the lack of standardized procedures and the high workload.
So with this case study, there are potential areas for improvement, one of them being double checking medication administration in hospital settings. This is often a standard practice and something that could be utilized to potentially decrease the amount of med errors. So there was an article and a study conducted where there were 5 databases that were searched for studies evaluating the use and effectiveness of double checking on reducing medication administration errors in the hospital setting. And of these studies, there was one that showed no association, one that showed a significant association, and the third one that only showed adherence rates. So the conclusion for this study was that better studies need to be designed to measure the benefit of double checking medications before administering them, because there's not enough evidence to conclude that double checking versus single checking medications would decrease the risk of committing a medication error. There are some other alternatives for improvement. Utilization of handheld personal digital assistants is one of them. It has been found to have improved medication errors. It includes real-time patient information, drug information, medication lists that are specific to each patient, and an increased ability to be able to document. Other ones include keypad backlighting for systems like the Pyxis or Omnicell, because they allow for nurses to be able to see letters and numbers more accurately on the keypads, which would prevent a misspelling when looking for medications. Implementing separate screens for concentration of drugs is another suggested change, because it prevents error when administering medications and nurses are able to be aware of the correct doses per protocol. And then the last one that is suggested is maintaining tubing systems to prevent errors, because most medication errors often occur when traveling in tube systems around the hospital. And these malfunctions in these systems can cause medications to be delivered inaccurately, which slows the process of getting patients the medications they need, and thus could present with further errors that are shown in the hospital setting.
So the actual areas and ideas for improvement for this problem, I found a journal article by Himani Deswal et al., and they held a 4-module training session for nursing students in their second and third years. The modules were themed lectures, hands-on training exercises, small group learning, and a session by a nursing officer. Before the training, these students were asked questions based on their perceptions of medication errors. And then after the training, they were asked these questions again, and they had a positive change in perception. Before this training, most students believed it should be the doctors who catch medication errors, with none of the responsibility falling on the nurse. However, after the training, the majority flipped and believed that nurses should truly act as the last line to prevent medication errors. Also, 90% of the class agreed that this program would be beneficial to include in their learning in school after the conclusion of the training. Adding extra modules and hands-on training for medication errors in either nursing school or in the onboarding process may provide the knowledge that helps prevent medication errors. Changing the perception of how we look at this issue could also effectively prevent medication errors, because some nurses will often believe that we are just giving the medication rather than actively being a barrier to preventing errors. Changing the perception of the nurses could help prevent these errors. Even if it is the doctor who is writing the wrong prescription for a medication, us reading and understanding the prescription before we give it could potentially change how many medication errors we have. Human factors such as lack of knowledge, poor practice, and negative attitudes have been shown to be some of the main contributing factors in medication errors in intensive care units. On an international scale, Eastern nurses were shown to have adequate knowledge but poor attitude, while Western nurses were shown to have positive attitudes but lack of knowledge. The second stage in Lewin's model is change, and changing requires an understanding of what needs to be changed. In this scenario, there needs to be standardized procedures in place and increased staffing to reduce medication errors.
So I am here to discuss who assists with making these changes and their roles within the hospital. So there's 3 large roles in assisting with reducing medication errors. Those 3 roles are nurses, physicians, and pharmacists. Nurses administer patient medications, doctors prescribe those medications, and pharmacists prepare, review, and send the medications. There's a large process to follow when beginning a medication for a patient, starting with the physician's orders. Depending on the protocol in the hospital or the unit you work in, it can either be approved through the pharmacy or it does not need approval and can be approved by the doctor. Depending on the medication, the nurse will be able to find the medication in the medication dispenser, such as an Omnicell that we see at like St. Mary's, or we will have to wait for the pharmacy to send or bring it to the nurse's location through like a tube system. Nurses play a large role in medication administration, from education on medications to medication administration, double and triple checking orders and dosages, performing medication calculations, and much more. It is vital for the nurse to implement the 5 rights when administering medications. The 5 rights are used by nurses to prevent medication errors and assist with correcting a medication error before it is given to the patient or even brought into the patient's room. The 5 rights of medication administration are the right patient, right drug, right dose, right route, and right time. However, the role of preventing medication errors is not solely on the nurse's shoulders alone. It is also extremely important for pharmacists to perform something called medication reconciliation at the patient's time of admission. It's also important for pharmacists to review medication regimens, assist in preventing and participate in clinical unit rounds. While performing medication reviews, the unit or hospital's pharmacists look for correct doses, formulations, route of administration, indication, contraindications, compatibilities, side effects, interactions, efficacy, and adherence issues, as well as evidence-based treatment that goes towards the patient's treatment. However, in departments such as the emergency department, physicians often do not have pharmacists to perform medication reconciliations for them. This makes it the physician's responsibility to perform the medication reconciliation. Because the emergency department is such a high traffic and emergent area, it makes it easy for the unit to make medication errors. Unfortunately, this is a time-consuming task in a high-pressure environment. So this is our action plan that helps us improve issues for medication errors. So our refreeze, which is the 3rd step in the Lewin's model, is to continue education. So refreeze is establish a new status quo from what further change may be possible in the future. So continue education and evaluations through root cause analysis to further outline areas for change. Our SMART goal for this is nurses will collaborate to decrease medication errors by 50% within the next 3 months by implementing company policies such as utilizing double checks with other certified and registered nurses and using the 5 rights of medication administration. To identify necessary tasks, we identified implement education for all staff who manage medication on how to decrease medication errors, such as those nurses, physicians, and pharmacists I talked about. Second is implement medication error reviews through evaluations to understand the root cause analysis. And third is to create unit goals for managers to emphasize teamwork and collaboration and decrease medication errors. To allocate resources and assign responsibilities, we're going to look at the responsibilities for the nurse. Nurses administer medications using the medication rights, utilize other nurses as a resource for checking medications, but they also use interdisciplinary teams by utilizing pharmacy to ask clarifying questions regarding medications. Charge nurses and unit managers assign patients and nurses appropriately to prevent high and unfeasible workloads. And this is really important to make sure that the staffing workloads are at a safe and workable environment. For prioritizing tasks, education is our #1 priority. In this case study, it's evident that there's a lack of standardization of medication administration, and implementing education will allow the staff to be aware of the evidence-based practice that's already in place and influence the hospital standardizations to prevent medication errors. For setting deadlines and defining milestones, one way of setting deadlines is by breaking down a large goal into smaller goals. If the large goal is to achieve a reduction of medication errors in 3 months, we could reduce the medication errors by approximately 17 a month. This allows more milestones and deadlines for each unit to achieve. This is much more maintainable and achievable and allows one bite at a time. To define so for one milestone, we could celebrate accomplishments based on the results of the patient surveys regarding their medical experiences. So we could ask patients to turn in a survey regarding them, and then nurses can be rewarded for their efforts and determination to meet and achieve their goals based on this. And then creating a visual display that represents progress and achievements made closer to the hospital goals will help the staff visualize the trajectory of their work. This will just be a physical form that will help them. And then lastly, monitoring the progress. Throughout the action plan, there needs to be a way of monitoring the progress or lack thereof for adjustments to be made. And one way of doing this is to have a monthly meeting with the nurse managers of each unit to discuss reports, goals, and achievements. Another thing to discuss during the meeting is how the units are achieving their monthly improvement on the unit or not. And if the unit is having difficulty with improvement, we could meet with them privately in a separate meeting and discuss alternative ways to improve their medication error goals within their unit. Lastly, these are our references, and we want to thank you for taking the time to watch our video.